Welcome back, guys. So again, this is Dr. Severin. Like I mentioned in the previous video, I wanted to spend a little bit more time talking about these concepts just because the flow volume loop, the time volume curve, these are just things that really is what we make our assessments from. And really want to make sure we have enough time dedicated to that. So the first plot we'll look at that is provided from an FVC maneuver or any PFT of any kind is the flow volume loop. Now, the flow volume loop, again, this is not a measurement. That we don't have a unit of time provided here. We have volume on the x-axis, so lung volume, and then we have airflow, which is rate, on the y-axis. Right? So this is flow rate in liters per second. The test involves 2 cycles, right? So the patient starts ideally at residual volume, so the air is completely removed from their lung, and they take a deep breath in, fully breathing in. So the top part of the y-axis, or the positive side, is expiration. And the bottom is the inspiratory maneuver. Remember, there's both parts with the test. Sometimes some devices only measure the expiratory component, but typically you measure a bit of both. And I'll show you why in a second. So they start here at residual volume. So again, where there's only just the air remaining that doesn't participate in ventilation or gas exchange. They fully inflate their lungs, and then they breathe out as forcefully and fully as they possibly can until they get back to residual volume, or the 0 point. Now you might see this, the x-axis plotted in a few different ways. You may see this as the 0 point. You may see this as numbers increasing left to right. Doesn't really matter, because what we're looking at here in terms of volume is when this point gets back to this point, and the value between here would be the FVC. Okay, the FVC, which again, if we start from total lung capacity, and we're assuming this point here is at residual volume, right? It doesn't matter what the unit is starting here now, because it's an absolute value. So this point from here, this 0 point to this 0 point, this distance here represents the FVC, the volume that they've moved during this expiratory maneuver. That would be the FVC. Okay? So we can make a few inferences from looking at this test. One, we can see, were they able to get back to that 0 point, that starting point? And we can also look at the flow rate. Now, in a normal, healthy individual, the peak flow, right, or the flow at the very beginning of the breath out rapidly increases. It's at its highest, okay? And then it gradually decreases. Now, there are some conditions, obstructive defects, where we see changes in this and actually flow rate decreases. But again, in a normal, healthy situation, the flow at the beginning is at its peak, and then it gradually decreases as we get closer and closer to residual volume, the end of the FVC maneuver. So again, the FVC maneuver really, while there is an inspiratory component because we get them to total lung capacity, full lungs, the volume that we're assessing is moving from this point to this point. Again, it's this value, that's the FVC. And if we know what residual volume is, we can add this value to residual volume and get total lung capacity, right? TLC, not the band, the lung volume. So that's that maneuver here. So again, this test is not timed, right? Or we don't have a time axis here, but it should take, when we do a spirometry test, a good 6 seconds. And it's really important that they get to a good 6 seconds, or at least that they get to full effort, because if they are not really getting all the way to residual volume, it's going to bias our test. We're not going to get an accurate measure of FVC. A way for us to kind of determine what the effort is, as well as looking at that flow rate, because we mentioned there are certain conditions where that flow rate drops off. We can look at peak expiratory flow. So again, like I mentioned, at the very beginning of that expiratory maneuver, that FVC maneuver, right? Which again, they breathe in all the way here, and then they begin to breathe out, and we measure the volume being breathed out during that interval, and we look at the flow rate changes over time. Now, the top part of this, the peak flow, right? The value for that would be the peak expiratory flow. What is a peak? The highest instantaneous airflow rate during the FVC maneuver. It's a way for us to determine their effort because we can compare what their flow rate should be like compared to their age, height, sex, and ethnicity, and sex, male, female. And we should expect this between 80 to 100% of what that value is. Again, this is an effort-driven test. If they're not giving us a really good high number, that could indicate a few things, but also could indicate that, this wasn't a true maximal test. The FVC, the maneuver may be a little bit biased. It might be skewed. We can also look at the force expiratory flow between different intervals of this maneuver. So we can look at what is the flow at 25% of the maneuver, what is the flow at 50% of the maneuver, and what is the flow at 75% of the maneuver, right? Because again, this change from this peak expiratory flow should be gradual in a normal, healthy individual. In patients with an obstructive defect, we might see this drop off very rapidly, right? The curve, we say, in this situation, will be scooping, okay? So we can look at the average of the flow between these points here, right, to get an assessment of what's the average flow. Because again, there are some conditions where flow rate drops off rapidly. We can compare that between what we see, at peak and what their values are compared to time. Okay, so expiratory flow can be very, very, very useful to look at, again, for effort, as well as what are the changes in flow rate and what may be causing the limitations in their lungs. Again, these are all patients undergoing these assessments in the clinic that have dyspnea. This is a way for us to figure out what's causing their dyspnea. Now, there are inspiratory flow measures as well, FIF, and that, again, is kind of an effort-driven test. They actually get to total lung capacity. They take a really forceful breath in before they started that FVC, or force expiratory maneuver. Now, the other plot that we'll look at created by this test, and I do want to stress too, the volume time curve here. The volume time curve and the flow volume loop are both assessed from the same maneuver. The patient doesn't have to do two separate tests. The computer produces a volume time curve and a flow volume loop. I don't do two separate tests to get one just for volume time and one for flow volume. It's the same exact test, just two different points of data that we assessed. All right, two different lenses that we assess the same test from. So volume time curve, on the x-axis now we have time, right? We have time in seconds, so this is 0. And then we have volume here on the y-axis here, volume, okay, in liters. And from this, we can get the FEV1 value and the FVC value, okay? Again, remembering, typically people get to FVC at roughly about 6 seconds. If they give us a good test, they'll go to about 6 seconds, and then they'll be back at residual volume. There's nothing else coming out. Again, looking at this again here, they give us a good test. They get to FVC when volume is back at that starting point, and the flow rate is 0, right, as low as it can. That's a normal test. Test ends when there's no more flow. So that should take about 6 seconds. So the volume time curve, we can look at what was the volume they breathed out or expired at 1 second, which is the FEV1, compared to FVC. You might see this at FVC 6. Again, most people, they should be getting to FVC at 6 seconds if it gave us a good test. Now, in a healthy patient, they are able to expire 80% of the air during that FVC, 80% of the volume at 1 second. Meaning that if we compare the volume at this plot here to this plot here at this point there, this should be 80% of that value for a normal, healthy individual. Now, there are some conditions where that changes, and we'll go over that. So again, FEV1 is, we get that from the volume time curve. We look at the volume expire during the FVC maneuver at the 1 second point and at the end of the test, okay, when there is no more volume being moved out of the lungs, okay. Again, we should get 80% of this volume out in the first second in a normal healthy individual. The ratio should be 0.8, okay. Now, in certain conditions, this changes. So on the right side, we have our volume time curve or spirogram, and then we also have our flow volume loops. So again, just looking at these volume time curves, I think this kind of illustrates our point. So A is a normal. This is normal. This is an obstructive defect. And this is a restrictive defect. Okay, so we'll go through them together. Right? So remembering that our FEV, FEV1 to FVC ratio should be 0.8. Okay, right? It should be 0.8 in a normal healthy individual. That risk ratio should be 0.8 in a normal patient. Okay, so let's look at the volume here. This is an FVC, 6 seconds. Okay, they get out 5 liters in a normal healthy patient. 5 liters. Okay, so what was their value at 1 second? Well, that's about 4 liters. Okay, so this is FEV1 here. This is 1 second. This is FVC. 5 liters. FVC. Okay, so let's look at our plot. FEV1. That is 4 liters. All right, so we do 4 liters over 5. Okay, that equals 0.8. That's normal. It's a good thing. Okay, so that's what a normal plot would be like. They get 80% of that volume is moved within the first second. Okay, so 80% of what they're going to get at their maximal expiration, they accomplish that within first second. The FEV1 is 80% of the FVC. Now, in an obstructive defect, this changes. So let's erase this here. Okay, again, remember normal is 0.8. All right, so in our plot B, at FVC, which is their FVC here, they get out about 4 liters, okay? So not too much lower than normal, right? Again, we'll talk about that in a second, but their FVC is 4 liters. Okay, so where do they get out at 1 second? Okay, so we're going to follow this line. All right, they got out at 1 second about 2 liters. 2 over 4. That equals about 0.5. Okay, so that would be less than normal. And an obstructive defect, their FEV1 FVC ratio is typically 0.7 or less. Okay, that indicates an obstructive defect, less than 0.7. That's not a good sign. So again, their biggest reductions at that first second. Now, if we look at our restrictive defect, which is plot C, so let's get rid of this again. Ooh, nope. I want our eraser. So I'm going to erase that much. So a plot C, which again is our restrictive defect, at 6 seconds, they get at about 3.5 liters. So this is their FVC. And then at 1 second, let's call that 3.2 liters, maybe 3.2. So we plot that here, 3.2. Again, this is FEV1 here. And this would be their FVC. So 3.2 over 3.5, it gives a ratio about, 0.91-ish. And again, with restrictive disorder, their FEV1 FVC ratio is usually either normal or increased, right? So it might be greater than 0.8. And that's because both FVC, their maximal volume expired, and the volume at 1 second are both decreased because the lungs are just getting smaller. And a way for us, another assessment we can kind of glean from this, again, is looking back at our flow volume plots. So again, in a normal, healthy individual, again, the reduction in flow rate is gradual until they get back to residual volume. So they start here, breathe in. This begins the maneuver, breath out, flow rate peaks, and then it gradually decreases throughout the maneuver, okay? Now, in this example here, we can look at flow, we can look at obstructive defects. So peak expiratory flow, and then they get out, a lot less, okay? So they have, they have a peak here and they have a huge reduction in flow rate, or what we call expiratory scooping, right? So their big issue is they just don't have enough velocity. So the other thing we can compare, which is very similar to our volume time curve, is they still get back, right? They still get back to FVC, right? Their FVC is not much different than it is in this healthy individual. It just takes them a little bit more time because they have an issue with flow rate. So for them, if they get a little bit more time, they can get all that air out. They just don't have the rate to do it, right? So they need a little bit more time. So their FVC is typically preserved. Again, remembering FVC is really this point to this point. Okay? So for them, again, we see big reductions in peak expiratory flow. FVC is preserved roughly, and the biggest hit is what we see occurring during the first second. Again, this is another example here, B. Restrictive disorders, we can just look again, the volumes are just smaller. FVC is reduced, and again, if we look at our plot on volume time, both are reduced similarly. Now, an easy way I think to compare both of these is looking at our kind of graph here, just give you an understanding again, volumes that change in a obstructive defect. Their total lung capacity increases, TLC increases, and that is primarily due to an increase in residual volume. Remember, obstructive defects have that air trapping, okay? Air that's just can't get out of the lungs. They have problems getting air out of the lungs. Again, think obstructive, think air out problems, okay? Including a reduction in ERV as well. And you can even see an increase in FRC, meaning that there's just more air in the lungs even after a normal breath, let alone a maximal breath out compared to normal. In a restrictive defect, total lung capacity decreases. The lungs are just smaller. Everything is smaller. Even the tidal volume they breathe in is smaller. That's why they typically have really fast rates in these patients, because they just don't have a lot of volume to work with. FVC is decreased as well in these patients. So everything is smaller. And that's kind of why FEV1 and FVC ratios are preserved, because the FVC is also decreased. not only do they have fibrosis and scarring and damage to the lungs are just smaller, a restrictive defect. So in restrictive defect, total lung volumes are decreased, everything is decreased. That's why ratios are typically preserved. And again, you can see reductions in residual volume in these patients as well. Now, when we're looking at these diseases, in terms of prognosis and staging severity, so COPD, anytime we look at a pulmonary function test, we want to look at the FEV1 FVC ratio. That gives an indication right off the bat, are we looking at an obstructive defect or a restrictive defect? And remembering again, patients coming to your clinic to get a spirometry test or pulmonary function test done are going to have dyspnea. So we're very rarely going to be testing this in a normal, healthy patient. So if we look at FEV1 FVC ratio, we're probably not expecting it, to be normal when looking at other things. FVC will let us know obstructive, restrictive, because we know obstructive will be less than 0.7, and a restrictive, it will be normal or high. Again, these aren't going to be healthy patients we're typically assessing this in. Okay, so just to kind of clue you in. So if we look at FEV1 FVC ratio, if it's less than 0.7, we're thinking obstructive. And then we stage severity by the percent predicted FEV1. So again, we look at their FEV1 FVC ratio is less than 0.7. And then we look at the percent predicted FEV1. If it's still, above or equal to 80%, we call that a mild. If it's between 50% to 80% predicted, we call that moderate. Severe would be 30 to 50%, and then very severe would be less than 30% predicted FEV1. Again, remembering COPD is hallmarked by the expiratory flow limitation, problems getting air out. So it would make sense that we stage severity of an obstructive defect by the FEV1, which reflects, how well or how poorly they're able to move air out of their lungs. And especially in a short period of time at 1 second. A restrictive defect, again, we look at our FEV1 FVC ratio in a patient with dyspnea, and the value is normal or high. We're thinking probably restrictive defect. And then to assess that, we're going to look at the FVC percent predicted. So in someone with a mild defect, it's going to be between 60 to 80%, a moderate defect, 50 to 60%. Less than 50% percent predicted severe defect. Okay. Now to help kind of clue you in, because I know we've talked about a lot of different things here. So again, this is just our little matrix. So in a normal, healthy individual, again, we rarely do a spirometry in a normal, healthy individual because again, this is for patients with lung disease to diagnose them, to figure what type of defect are we dealing with. But anyway. So a normal, healthy individual, FEV1 FVC ratio will be about 0.7. We say the lower limit is 0.7. The normal limit is 0.8. A normal FEV1 FVC ratio, again, we're looking at the actual ratio, is 0.8. Okay, because again, FEV1 should be about 80% of FVC. So there, should be 0.8. FEV1 percent predicted should be within normal. FVC percent predicted should be within normal. TLC should be normal. Residual volume should be normal. DLCO we know should be above 80%. That's considered normal. Okay. So if we look at our FEV1 FVC actual and it's less than 0.7, think obstructive. Next thing we're going to look at then to stage severity is FEV1 percent predicted, which we would expect to be reduced. Another thing that can help us clue us in, we should probably expect total lung capacity to be increased because they're trapping and holding on to more air. Residual volume will be increased, again, because most of the increases in total lung capacity are due to increases in residual volume. And if it's an intrinsic disease like COPD, we will see DLCO also decrease because of the disruption of the alveolar capillary interface. I mentioned FVC. Again, obstructive defects, FVC is usually preserved. Again, if we go back to our plot, if we give them enough time, they're able to get all that air out. Their issue is, again, just that velocity equation. They just, they don't have enough time. But if they are given enough time, FVC is usually normal. Now, in some more severe cases of obstructive defects, like in COPD, they can also demonstrate reductions in FVC. So, if you have, very severe problems getting air out, sometimes you eventually develop problems getting air in too, and everything starts to decrease. So, in some instances, obstructive defects, FVC is also decreased, but it's hallmarked by that FEV1 FVC ratio, and that's still, even if this decreases in an obstructive defect, this is still below 0.7, even if this starts to change a little bit in those severe cases. Now, restrictive defect, again, we'll always look at our FEV1 FVC ratio first. This will either be normal, so, at around 0.8, or increase, because again, both FEV1 and FVC decrease in a restrictive defect. We would also expect total lung capacity to decrease and residual volume to decrease. Okay, the lungs are just getting smaller. The volume is just less. They have problems getting air in. Okay, right? The lung volumes are just small. They don't, either for it's an intrinsic disease or an extrinsic disease, problems getting air in. Obstructive, problem getting air out. And if it's an intrinsic disease, we will also see DLCO likely decrease. Now, a special caveat. Remember that we have asthmatics who have, will demonstrate an obstructive defect, so they'll have very similar ratios to, COPD, but it'll be reversible. So if we give them a puff of an inhaler, a bronchodilator, typically their symptoms resolve. And their DLCO will typically be normal, because even with an asthmatic with their obstructive defect, perfusion is still usually maintained, because there's nothing disrupting the alveolar capillary interface. With an extrinsic or mechanical restrictive disorder like obesity, or maybe someone with a scar on the rib, just a rib mobility defect, they'll demonstrate a restrictive pattern. And the values for FVC, TLC, and residual volume may be variable to a degree. It'll still be a restrictive pattern. But DLCO in an extrinsic, where it's not the lung tissue that's like fibrosing or something like that nature, the DLCO in an extrinsic restrictive disorder will be preserved. Now, I have a link on the bottom here to some examples from Washington University out in Washington State. I think are great. We're going to go over some PFT cases to help kind of get you guys to review things. So those will be there for you guys. So thank you so much.